Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Good morning. Breast cancer is the second most common kind of cancer in women. About 1 in 8 women born in the United States will get breast cancer at some point. Thanks to early detection and advances in research, survival rates are climbing, and we know more about breast cancer today than ever before. Good morning. I'm Dr. Roy Jensen, director of the University of Kansas Cancer Center. With me this morning is basic researcher Dr. Christy Hagan and patient research advocate Peggy Johnson, who work together to advance breast cancer research. Peggy is joining us via Skype, and also joining us on Skype is Megan Peters, who is here to take your questions. Welcome, Peggy. And could you tell us about your breast cancer journey, please?
I helped bring the Race for the Cure, the Komen Race for the Cure to Wichita a little over 30 years ago. And at the time, we just didn't talk about breast cancer. We couldn't get survivors to come out and identify themselves as being survivors. The race was successful, but we knew that we needed to be doing more. And through my work with Komen, I got very involved with public policy. And one of the things very early on that we were working for was more money for breast cancer research. At the time we started, there was about 66 million being put into NCI for breast cancer research, and we knew that wasn't enough. And that was one of the places where I really focused, was trying to get more money for breast cancer research. We were successful in adding money to the NCI budget. We were successful in getting the DoD breast cancer research program started at the time. We got the breast cancer research stamp, which raises money for NCI. So we saw some really good gains in those first years. And I got very interested in research, and through my association with Komen, I was exposed and got to know breast cancer researchers and how dedicated they were. I also started reviewing breast cancer research grants for the government, for an NCI program at the government, and Komen research. So then about 8 years ago, I actually was diagnosed with breast cancer myself. And I believe my journey was probably easier because I knew more. I knew who to call. I knew the questions to ask. And I knew that the type of breast cancer that I had was particularly difficult to treat because I had read so many research grants that were focused on triple-negative breast cancer. So I believe that my background actually helped me through my breast cancer journey. Then about 4 or 5 years ago, I was given the opportunity to be an advocate, a patient advocate on a research grant at KU, and that's when I met Dr. Christy Hagan and was able to visit her lab, visit with her lab staff. She's a wonderful mentor. She's very dedicated to breast cancer, and she just made my job as an advocate more important to me. And then I was given the opportunity to join Pivot, which is a program at KU that Dr. Jensen, you've been very, very involved in, and I appreciate your work in it, because it's actually bringing patient advocates, survivors, co-survivors, into the research arena with researchers so that they better understand what the cancer journey is and what research is really going to be important to them. So I've had a varied career. I have loved everything I've done, and I really cherish all the experiences that I've had, especially working with Dr. Hagan. She's got a wonderful research staff, and her research is so important.
Well, thanks, Peggy, for sharing your story. So now we're going to turn to Dr. Christy Hagen, and you are a breast cancer researcher, and you specifically focus on the relationship of breast cancer with hormones. Could you tell us a little bit about how you came to choosing that path for your research?
Yeah, so we've known for a long time that hormones are really important in driving the development of most breast cancers. We've known that for almost 100 years now. And when we talk about hormones, we're talking about two primary hormones, estrogen and progesterone. And estrogen has really been the focus of research for over 75 years. We know a lot about how it drives breast cancer. And as such, we have great treatments that are aimed at blocking estrogen and blocking its ability to induce breast cancer growth. On the same tune, we know that there's this other hormone, progesterone, that we just don't understand how it contributes with estrogen to promote breast cancer growth. But we know that you need both of those hormones. So we've tackled estrogen. We have great anti-estrogen treatments, tamoxifen, fulvestrant, some of those might be common names. But we still know that women can progress on those therapies and that women still get metastatic breast cancer and women still die. So we need to understand what other treatments, other ways that we can try to attack cancers. So that flips us to this progesterone. What is progesterone doing? And we know that the way that progesterone, that our lab has been studying progesterone, is how it impacts the immune system. We know that the immune system's one of the immune system's normal jobs is to surveil the body, to search the body, to look for small developing tumors, 6-8 cell tumors. And these small tumors start to put off little red flags or little danger signals to the immune system that says, hey, something is wrong in how this cell is growing. This cell should be detected by the immune system and destroyed. This happens on a normal basis. Well, what our studies show is that progesterone actually blocks the cancer cell's ability to put up those red flags. So now these small tumors can hide from the immune system, they're not recognized, and they can grow undetected, and then develop into tumors that may show up in the clinic. So we are understanding how progesterone is helping these tumors hide from the immune system. And the long-range goal is how can we then how can we change progesterone signaling in a way that we've blocked estrogen with the current therapies we have. Now what can we do to come in and hit it with a second whammy and block the progesterone signaling as well?
Mm-hmm. So if you're just joining us, we're here with Dr. Christy Hagen and patient research advocate Peggy Johnson talking about how they work in partnership to advance progress in breast cancer research. Megan Peters is also taking your questions, and please remember to share this link with people you think might benefit from our discussion. So Dr. Hagen, tell us about the progesterone study that you're engaged in right now, and why do you think that is so important?
Well, one reason is that we're looking at progesterone from a totally different lens than anybody else has looked at it before. When we think about cancer, we often think about it's growing fast. What can we do to stop the growth of the tumor, which is incredibly important, obviously, but oftentimes, until recently, the immune system has sort of been overlooked, in particular in breast cancer. And one reason is that breast cancers tend to just not be very visible to the immune system, and our hypothesis is because that's of progesterone. So we're doing studies where we look at, first of all, that how does the breast tumor, what signals does progesterone do to the actual breast cell that allows it to block all those red flags? So that's really pretty basic signaling questions. Then we're looking at if we block progesterone, so if we use antiprogestins, so there are commonly already available antiprogestins for treatments for other diseases. If we can use antiprogestins to block that signaling, maybe now does that tumor pop up a little bit? Is it visible by the immune system? And then we're also taking it one step further, which is to understand how can changing progesterone signaling make these tumors more susceptible to treatment with immune checkpoint inhibitors. So this has been a big advance, as you know, and probably many of our audience knows, a big advance in cancer treatment as a way to sort of reawaken the immune system to these tumors. And we are combining antiprogestins, blocking the progesterone signaling, as a way to then follow up with checkpoint inhibitors. Checkpoint inhibitors have traditionally done pretty poorly in breast cancer patients. And a lot of our work helps us understand why they've done so poorly. There is a small subset of cancers that do well, like Peggy. The type of cancer she had is one that is actually doing better on checkpoint inhibitors. But it would be fantastic to add checkpoint inhibitor treatment to the majority of breast cancers, which are responsive to these hormones. So that's kind of the three different layers of what we're working on right now.
So with the the role that progesterone plays in breast cancer, why do you think it is that the estrogen side of the equation has gotten so much attention, and you don't hear that much about anti-progesterone agents in the treatment of this disease?
Right. Well, it actually kind of goes back to really basic science. So the estrogen receptor was one of the first type of this family of receptors to really be studied in the lab by some of my mentors that I worked with in the past. And so it became one of the first tools that we could really study from a molecular level in the lab, partly just because it was a little bit easier to study because of it's how much it's expressed in a lot of breast cells. Progesterone and the protein that it works through, the progesterone receptor, isn't as highly expressed as estrogen. So if you're looking for a quick response, estrogen is really your first driver for growth. And then became really the avenue that was studied for so long. Progesterone has been a little bit trickier as a hormone because trying to block the progesterone receptor has turned out to be a little bit harder than it has been to block estrogen. And that gets down to sort of the chemical levels of those compounds and what they do. So antiprogestants have actually come a very long way in their specificity to actually blocking the progesterone receptor. And so it's kind of an interesting scientific timeline of why we really honed in on estrogen. And a lot of women also always ask, well, why, most women who develop breast cancer are postmenopausal. So why do we worry about hormone, why are hormones even a question in the development of breast cancer? And that's because when women are premenopausal, their hormones are produced in a different part of their body. They're typically produced by the ovaries, so progesterone is produced by the ovaries and estrogen. And then when women shift to postmenopausal, their hormones come down a lot, the levels come down a lot because the ovaries don't produce them anymore. But there are other sources of tissues, like fat tissue is a big producer of some of these hormones. And the breast is largely, has a lot of fat tissue in it, and unfortunately as women get older, we tend to put on a few pounds as we go through the menopausal transition. So there's more of a source of these hormones from fat tissue more so than ovarian. So the hormones aren't gone, they're just from a different source.
So, Megan, it sounds like we have a question from our audience.
This question may be for Peggy. The question is, how would one get involved with Pivot if they are interested in doing so?
Oh, what a great question. There are several avenues. I'm sure that you can send me, I'll give you my email address so you can send an email to me. We are welcoming new members all the time. We have trainings ongoing all the time. And so you can either email me at Peggy Johnson at WMREF-KS.org, and I will take your information and I will send it on to Sarah Douglas, who's our wonderful staff person who really keeps us all going. We would love to have new members. Like I said, we're training new members all the time. We have a lot of programs that you can be involved in, meeting researchers face-to-face and, well, right now on Zoom. We just have lots of opportunities. So I encourage you to either send an email to myself, or you can probably call the Cancer Center. Dr. Jensen may be able to answer that better. But you really do want to have the opportunity to work with researchers like Dr. Hagen, who are doing very interesting stuff, and they enjoy hearing the patient's voice. What does the research mean to the patient themselves? So I hope that helps.
Thanks, Peggy. I had another question for you, Peggy. As you and I have known each other for a very long time, and in fact, I think extending back to the mid 1990s. And what I'm curious about is that in your involvement with Komen, you were one of the few people there that actually, at the time, had not been diagnosed with breast cancer. And so. Right. I'm curious about what prompted your early interest in advocating for breast cancer patients long before you ever became a breast cancer patient.
So I'm a women's rights person and marched on the White House for ERA. And when I started looking at Race for the Cure and what they were trying to do, and they were trying to raise money for breast cancer, I became very aware that people simply didn't talk about breast cancer. I know that seems strange now, but I'm going to give you a statistic that's kind of an interesting one. So Nancy Brinker, who is the founder of Komen, used to use this, and it was very meaningful to me. It was during the 10-year period of the Vietnam War. 58,000 men and women died during that 10-year period. In the same 10-year period in the United States, 330,000 women died from breast cancer. So if you're old enough like I am that you remember watching the newsreels from Vietnam, we had a body count every day. They told us how many people had died in Vietnam that day, much like we're seeing them do with COVID today. Nobody was talking about the body count. And it truly was a women's issue to me. And my mother's best friend died from breast cancer, but we didn't talk about it. So many women would have breast cancer and not talk about it. Susie Komen was kind of shunned in her hometown because nobody wanted to talk about that she had breast cancer. So to me, it really was an equal rights for women.
Thanks, Peggy. Megan, it sounds like we have another question.
We do. The question is, what if your cancer is estrogen positive but progesterone negative? Would this change my treatment?
That's a great question, and one that our research is directly trying to answer. So that gets into sort of so estrogen and progesterone, while we talk about them as separate hormones, actually work really closely together. One of estrogen's jobs is to turn on the receptor for progesterone, so they're actually very tightly linked. And in that type of situation, the reason why it's important to know if you are estrogen receptor positive and progesterone receptor positive, which many patients will hear in their diagnosis, is if progesterone receptor is positive, if it's there, that gives us an indication that estrogen receptor is working well and that we can target estrogen receptor in with these anti-estrogen therapies. How that's going to affect it from the immune standpoint, it's just too early to tell. That's exactly what we're working on. If it's progesterone receptor negative, that doesn't necessarily mean that targeting the immune system would not work. We also have separate studies going on showing that progesterone not only affects the breast cancer cell's ability to escape from the immune system, but it also seems to directly affect the immune cells themselves in the area of the cancer. So in that situation, you wouldn't necessarily need to be a PR-positive breast tumor because you're directly affecting the immune systems that are talking to the breast cancer itself. So that's a great question, and one that I hope lots of people are interested in. Stay tuned. Stay tuned for what our studies show.
Particularly, let's hope NIH study
exactly.
section members are interested. Yes.
Particularly one meeting in 3 weeks.
Let's cut to the chase. Yeah. So, the other rationale for testing for both is that there seems to be a difference at a molecular level between tumors that are positive for both estrogen and progesterone receptor and tumors that are just positive for estrogen receptor. And there also seems to be a little bit of a difference in terms of response 2 anti-hormonal therapies for tumors that are progesterone receptor negative. So, we're learning more and more about the different differences at a molecular level between these 2 types of breast cancer, and I would dare say that Dr. Hagen's research is really at the crux of that whole issue there. So couldn't have a better expert on this morning to talk about that. So we're approaching the end of today's episode, and I just want to ask, what are you most excited about when it comes to the future of breast cancer research and treatment? And I want to get both your opinion, Dr. Hagen, and Peggy's opinion on that.
Well, mine, and it's going to sound terrible because it's what I work on, but I really think that how the immune system talks to cancer in general is such a really interesting question, and one that we're seeing is a great way to start to target cancers. So seeing breast cancer come into this realm of these 2 worlds meeting, how can we target the immune system and breast cancer, I really think is sort of our next leap in making our next big advancement. And it's not just because it's what I work on, but that's one reason why it's exciting to us. So that's kind of where my thoughts are.
Yep. And Peggy?
I'm going to tag on to Dr. Hagen. I will tell you, when I was invited to be the patient advocate on her grant, I had never really heard much about the effect of progesterone on breast cancer. And so one of the things I was really excited about was this was research I really didn't know much about. And so I'm really encouraged because there are researchers like Dr. Hagen who are thinking outside the box. And immune therapy, we know, hopefully will be a focus of the future. We hope the treatments will be easier to tolerate so that patients can have an easier journey during their breast cancer treatment. But the other thing I'm excited about is that we have young researchers like Dr. Hagen who are mentoring more young researchers to continue to be in breast cancer, and that's what we need. We need to keep as many researchers in breast cancer and bringing them more into breast cancer. That's why public policy is important, because we've got to have those dollars. We really have to have those dollars so that we can keep them in the lab and we can keep the young investigators like Dr. Hagen and her staff employed and excited about what they're doing.
That's a great summary there, Peggy. And I want to thank you, Dr. Hagen and Peggy, so much for being part of this week's episode of Bench to Bedside. And before we sign off, Megan, do we have any other additional questions?
We do. We have a question from Mary that says, are you studying if lifestyle can improve the immune system in addition to medicine?
Another great question, and I myself am not studying that, but there is a team here at KU studying just those questions because we know it's not just one thing. There are a lot of different factors that can affect how the immune system works. So we have a team at KU that's actually involved in some early stage clinical trials looking at how lifestyle factors, obesity, exercise, how that impacts the immune system and how that affects how patients respond to their treatments. So another great question of research happening here at the KU Cancer Center.
To learn more about breast cancer, please visit kucancercenter.org/breast cancer. That's it for today. Join us next week at 10 a.m. for Bench to Bedside. Thanks for watching.